So now let's move ahead with today's clinical topic. And our speaker is Dr. Shankar Iyer. He received his dental degree and specialty certificate in prosthodontics from NYU. And right now he's on the faculty at the Rutgers School of Dental Medicine. He's a past president of the AAID. And Dr. Iyer has trained hundreds, well, probably thousands at this point, of dentists around the world on implant dentistry. He's lectured in over 20 countries. He's the co-director of the Rutgers AAID Maxi course. And even more importantly, he's getting ready to start the first West Coast Maxi course right here in Newport Beach. So I know all these folks on the West Coast that haven't had access to a Maxi course. This is a great opportunity. And he's got a great topic today, and I'm looking forward to hearing his lecture on biomaterials and biomechanics, understanding the fundamental concepts for implant treatment planning. Shankar, it is an honor to have you back, and I'm going to turn it over to you right now.
Thank you so much. Thank you so much, Neil. And my vested interest to be participating in this program is to listen to the pearls that precede the actual lecture. What a great advice from Roger and from Gary, and of course from my dear friend David Hochberg. You can see now why he was chosen as the president of the American Academy of Implant Dentistry. What a great leader and a terrific friend. Thank you. And thank you, Neil, for inviting me. And thank you, Megan, for organizing this, and also for Nicole. It's a pleasure to be part of this entire educational endeavor on a Friday morning. And I hope we can bring back some pearls from this interaction. So my topic today is about biomechanics and biomaterials. Everyone is interested in actually knowing the surgical aspects of implants. If you take a course, the first topic would be, how do I place an implant, or what are the surgical concepts that are involved in learning the nuances of surgery. They also go on to do some prosthetics. But many a times, the fundamental concepts of biomechanics is often overlooked. And what do we mean by biomechanics? If anything heavier than air can fly, that's an example of biomechanics. If a bird can fly across the Atlantic, you know that there is an element of biomechanics involved. And the fish, when it's swimming through the currents, you know that's an example of biomechanics. But what good is it for the human body? We are now able to understand the principles of wound healing better than before in terms of how the bones and joints heal. And that's an example of biomechanics. About 50 years ago, if someone had a car accident, this is typically how a patient would be confined in a hospital. In today's HMO world, this is not possible. You can't even stay there for 2 days. And patients are walking in a walking cast the very next day after an accident. So how is it that the human species changed with the advent of insurance companies, or is it our understanding of the biomechanical principles of wound healing? So it behooves us to understand what it takes to actually make an implant heal and function long term. The best days of a car is when it's in the showroom. The best days of an implant is when it's in the vial. And you all know that as you keep driving your car, one day it's going to end up in this junkyard. The same thing is probably going to happen to our implants too. It is not about an infinite rate of success. Patients ask us, how long is this implant going to last? Earlier, we used to say it's a lifetime worth of service. Now, what do we mean by lifetime? So it's really not defined well as to how long an implant is going to last. So why should it be attributed to biomechanics? So when you look at failures of surgery, they announce itself right away. So within about 3 months, you'll get to know that this implant is failing as a result of a surgical failure. It could be whether the implant is contaminated, or the surgical technique was poor, or the patient's health history did not permit proper wound healing principles. So surgical failures are easy to determine. We have never seen an instance of a sleeper fail, And what's a sleeper? A sleeper is an implant we don't use. It could be an expensive, rich preserver, but we have never seen a sleeper fail. So the only thing that points to an implant failure would be post-abutment connection. The moment you put an abutment on, whether it is peri-implantitis or whether it's an overload, we start the demise of the implant. And we talk about lifetime warranty. We need to be careful about how we present warranty to our patients. So, what are some of the biomechanical concepts that are affecting our long term prognosis? Component fatigue and fractures up to 33%. A third of our components could start to break down over a 10 to 15-year period. Implant fracture used to be quite high with about 21%. And this is directly from Charles Goodacre's article in 2003 and also from Duncan. And of course, the fracture rate have decreased tremendously because we have better materials that are being used to manufacture implants. Occlusal material fracture up to 68%. Two-thirds of our occlusal materials can potentially fracture over the lifetime of the course of the implants and function. So we are looking at a very high morbidity rate when it comes to long-term survival. So when we look at all these different types of biomechanical factors that are affecting dental implants, there are a slew of topics that we could be discussing. So what we would like to do today is to go over some of the aspects of biomaterials. We will look at length. We could probably look at diameter. We will probably be looking at whether we should splint implants and whether we have to have cantilevers. And if time permits, we can also talk about some immediate load. So we will pick a few of these topics to be able to discuss what is it that we need to be thinking about as we treatment plan our cases. So let's start with biomaterials. It starts by understanding what is modulus of elasticity. This concept has been spoken about a lot, but let's understand what it means to know about modulus of elasticity, because it is one of the prominent components of long-term survival. Stress over strain is the formula. What is stress? It is force per unit area divided by change in dimension over original dimension. It's a very simple formula. So if I ask this audience, which is more elastic, whether is it an elastic band or is it a steel rod? Now, a majority of you would probably pick the elastic band because in our mind, the elastic means it is able to come back to its original shape. But let's look at the formula and see which is more elastic. If I placed about 10 pounds of force on 1 foot of rubber band, it would probably expand to about 10 feet. So when we look at the modulus of elasticity, you're looking at 1 as opposed to placing 10 pounds of force over 1 foot of steel, it will probably go to about 100. So a steel rod is more elastic than a rubber band. So what does it mean for us from a clinical perspective? If our modulus of elasticity is not comparable to the bone or the components that we are using, you are exposing these implants to greater fracture rates. So when we look at the wears of bars or fractures, they are all directly attributed to the complications arising as a result of mismatch in the modulus of elasticity. This is a very old graph that Jack Lemmons used to describe modulus of elasticity. It is still valid today. So when we pick a device like titanium and bone are very, very close. And that's the reason we use titanium as a dental implant. And titanium alloy is a little stronger. Chrome cobalt is even more stronger. This is unforgiving. And when we look at the next level of the modulus, it is zirconia. So when we are trying to use implants that are going to be closely matching the modulus of elasticity of bone, it has a better conformity to the stresses. So when we are trying to use an insert, okay, this is prosthetic implication, made out of zirconia, the likelihood of fracture of these inserts is very high. So we are walked away from utilizing zirconia connections into the implant for two reasons. Zirconia is stronger than titanium, so zirconia will wear off the titanium body. So we normally do not recommend having a full contoured zirconia insert going inside a titanium implant, and the fracture rate becomes high because zirconia is brittle. So this is why we are using tie bases so that the titanium can have the same modulus of elasticity as the actual implant. So we should not be using zirconia bases for any of our restorations. And we also see implant fractures. If you really don't know how we are going to be managing these implant failures, look at what is the component that is used to manufacture implants. So our implants ideally should be made out of titanium alloy. So titanium alloy is strong enough to be able to resist the loads when you can have it freestanding. Okay, so now when you are going to be talking about all these different types of biomechanical concepts, um, all this will be discussed in detail at our newest Newport Beach Maxi course right at the Gleitwell Center. Thanks to Neil and his entire team, we are now bringing a new flavor of scientific foundation to implant therapy. It is not just about pieces and parts and implant surgery and prosthetics. It is going to lay a scientific foundation for your implant career. And it's about 300 hours long. And Dr. Honkberg here is a doyen of the Maxi courses because he took the first course in 1986 under Terry Reynolds, and he will speak volumes of the importance of Maxi courses. So this is coming right to California, and I'm excited to join hands with Glidewell to be able to float this course. The next concept would be the crown root ratio. Everyone talks about crown root ratio as being very important. We need 1:1 is what everyone says. You need one portion of the implanted bone and an equal component to the prosthetics. So if that is true, how are these implants surviving? These are all implants that are known to be used in deficient bone. So is it true that we could use short implants, or do we really need very long implants, which are, 20 and 30 millimeters long? So let's look at the usage of short implants. Short implants have been used widely when there is deficient bone. So if you had a choice, should I be doing vertical augmentation or should I use a short implant? Most of the clinicians will tell you that vertical augmentation is not as predictable. So that's the reason why short implants are preferred in some of the areas where you cannot do bone augmentation. Meanwhile, there are practitioners who feel they need to use very long implants. But in essence, when you use a regular implant and you start to see bone loss, you're starting right here with about 50% of the implant in bone. And now I'm dealing with almost 2 parts or 3 parts outside. So when you have bone loss on a long implant, that pretty much translate into a short implant. So where is the place for short implants? There are a lot of studies that have shown that implants less than 10 millimeters have a higher failure rate. And you could see many of these are reputable researchers. Then when you look at another set of articles, these are an equal number of articles that say short implants work just as good as long implants. And when you look at the authors, they feature on both sides. So what happened here? So by about 1997, 1998, the implant surfaces changed. We walked away from machine surfaces and started to use blasted surfaces. Surface treatments became very popular, and short implants became very popular. And that's the reason why we are starting to see an increased use in the short implants, because our understanding of biomechanics, our understanding of surface features became um, more evident. So when we look at the length, I want to draw a parallel between structural engineering, architecture, and dentistry. So these are all some of the world's known skyscrapers. The first one, of course, is MetLife building right in Midtown Manhattan. The second is Burj Khalifa, that's in the desert, Dubai. The third one is the Petronas Towers in Malaysia. And the fourth, of course, what used to be the iconic Twin Towers. So if you apply the principles of crown root ratio, and we talked about how deep the foundation should be for these structures, that will kind of point to our ability to use implants in different areas of bone. So if you were to take a guess and give a number as to what would be the structure to the foundation ratio, it is quite interesting to note that they don't really follow a principle of ratios. They look at the soil testing. The tallest skyscraper in the world, which stands at about 850 meters tall, has only 70 meters into the soil, which is sand. So they had end-on pile foundation, which is able to resist the loads of 850 meters of steel and concrete. The Petronas Towers is about 120 meters, where they didn't have the technology that they had in Burj Khalifa. Well, it's interesting to note that the Twin Towers only had 70 feet of foundation. You had, in that 70 feet, you had the path station, you had the garages. So in essence, there wasn't much of a foundation to begin with, and that was all in reclaimed land. And let's look at the MetLife building. The MetLife building has zero foundation. You already had the Grand Central Station in existence from 1905. MetLife building was only built in 1972. So when you look at the foundation, Manhattan doesn't have any kind of foundation for its skyscrapers. So they can get away with these tall skyscrapers because Manhattan was built in Manhattan schist. So when you translate this and bring it to the jaw, and you can see where many of these foundation aspects will play a role in implant crown root ratio, it's interesting to note that the crown root ratios do not apply for dental implants. And this is one of the earlier studies by Ralph Blaine, who says that crown implant ratios between 2 and 3 may be successfully used in posterior areas of the jaw. And when we look at the different factors affecting the success of implants, density has a role to play. In D1 bone, there's absolutely no sense in going with long implants because you're not going to be able to have any kind of stress transfer with implants greater than 10 millimeters in dense bone. Whereas when you're dealing with D4 bone, you probably may think that length would play a role in terms of primary stability. Platform switching, whether you're placing the implant to load right away or are we delaying the load? Eventually, it all boils down to the bone implant contact. So this is a good friend of mine, Jihad Abdullah. He does not do sinus lifts. Most of his cases are done subcrestally with these short implants. So the current literature shows that crown implant ratios of implant-supported reconstructions does not influence peri-implant crestal bone loss. So to test the proof of concept, I had this case that I treated some years ago. The patient came in with a periapical lesion, and I get a lot of referrals. So this was another referral. So I told the patient that that she would have to get some grafts done and probably some crestal lifts too. So the tooth was extracted, grafting was performed, and the implant was placed. Right about then, we noticed that there was a periapical lesion. So I told my referring dentist that she needs to retreat this, or rather do an RCT before it starts to affect the implant. So she completed the root canal, and by the time I got the case, it was a little too late. The infection had spread to the adjacent implant. So there was no evidence of mobility. The implant was asymptomatic, but there's a fistula that is arising from the apical areas. So this is the fistula that was noted, and it was quite obvious that the periapical lesion had spread to the apical areas of the implant, and now it is manifesting as a fistula. In the absence of mobility, I did an apical exploration, made an osteotomy to get to the apex of the implant, debrided the entire apical areas, only to find that almost 50% of the implant at the apical region was floating in granulation tissue. So this attests to the fact that 80% of our load is transferred to the crestal 20%. So if this implant was only this long, it would have fared just the same without us knowing that there was anything wrong with the crown root ratio. So now I debrided to the best of my ability around it, and there was no way to get behind the palatal aspect of the implant. So I decided to do an apicoectomy on the implant and remove the apex, debrided, degranulated, and grafted the site. So in essence, now I'm dealing with a short implant. So this is the overall length. So crown root ratios need to be looked at more closely. And this is why some of the short implants are still viable in today's treatment planning. Then this patient came along for a total reconstruction. And if I were to ask you which was the implant, of course, it's very obvious. It's number 10. If I did not show you the radiograph, you would still be able to guess it as number 10 because of the intrusion of number 10. Now, this patient has mobility, bone loss, and number 10 was quite firm. So the patient was asking me, can I save number 10 because I paid for this implant years ago? Maybe you can use that when you're doing a full reconstruction. I looked at the scan, and you will be amazed to see that almost 90% of the implant is outside the confines of the bone, completely asymptomatic. So whosoever was doing the implant probably went through the apex thinking that they are in bone, because most likely CBCTs were not taken at that time, and they kept using a long implant till they reached sound bone. Obviously, this entire implant is in space. So only the lingual aspect of the implant is being held in bone. So this is the total support for this entire implant for 15 years. No evidence of peri-implantitis. Patient was asymptomatic. So sometimes you see that the clinical reality defies our conventional understanding of implant design surfaces and peri-implantitis. So in essence, you could see that the crown root ratio here didn't really apply. And the amount of bone implant contact was what made the implant survive all this time. So you're looking at about 6 to 7 millimeters of thread on the lingual aspect holding this entire implant. So guidelines when using short implants, if you're going to need primary fixation, then length could be one of the factors. So crown root ratio is not a factor after integration. So if you are not going to be loading the implant right away, and we find the bone is soft and you can't do a sinus lift, You could very well use a short implant, let it heal for the full 4 months, and then magically that bone is going to become D2 because we know from Wolff's law that a change in the internal architecture and the external form of bone is directly proportional to the functional forces placed upon it, which will further attest to the fact that the bone constantly remodels. So if you're not going to do an immediate load, short implants work just as good as long implants. But however, failure rates could be higher when the bone implant contact is low. In other words, if your implant design is faulty, you have a subtle design in soft bone, the bone probably is not going to be able to anchor that design good enough. And this is what we used to see with the Brannamark system when they had a subtle thread design and the bone quality was poor. The surface was also smooth machine surface. And Charlie Berman came up with the paper in 1992, blaming all the failures to the bone quality, didn't really attribute it to the implant design. It's a great adjunct to manage posterior mandibular atrophy. Rather than having cantilevers, we could place two short implants and avoid the cantilevers. So, what are the predictors for failures for immediate load? This study by Kinsel says in the retrospective analysis of 56 consecutively treated edentulous arches with multiple single stage dental implants loaded immediately, reduced length was the sole significant predictor of failure. So, if you want to load an implant right away, you certainly need length. And if the anatomical limitations are present, then the advice would be do not load it right away, even though you may have 50 newtons of torque at that point. So this is a small formula that I created. For every millimeter increase in length, the surface area increases only about 5 to 6%. For every millimeter increase in diameter, the surface area increases 25%. And that's again in Carl Misch's textbook where he talks about diameter being a major factor. So let's look at the CREST module. This is the age of innovations and designs. Here's the original classic Brannamark external hex. This fell out of favor because of screw loosening and fractures. So we then decided to go internal. So the internal connection has its own set of problems that we are still battling. So what are the problems with internal connections? Not all internal connections are made the same. Sometimes you have an internal connection which could compromise the wall thickness. And we'll talk about implant designs and the wall thickness as it relates to implant fracture. So one of the issues with having these kinds of internal connection is the fact that once you have this internal connection, the wall is now going to become very, very thin. So if the material of construction is not titanium alloy, you could end up with a fracture. And that is what we've seen with many of the current designs as well. So the first question to ask your implant manufacturer is what kind of titanium are you using for your implants? Okay, the preferred materials, of course, TI6AL4V. So the Brannamark design, which had the external hex, was really not favored because of bone loss. So what did they say? Well, bone loss will go to the first thread when you use this external hex because you have a machined collar. This is going to cause some bone loss. And then as you saw that the bone loss go to the first thread, they said, let's go internal and bring the threads higher up. And this is from Carl Misch's textbook, where he did mention about the lack of force transfer on the threads. So whenever you have a parallel walled implant, the threads start apical to the connection, there's a potential for bone loss to occur and progress to the first thread. So everybody started to change their design, and the implant companies also started to introduce micro threads and threads going to the top. So there was a race by all companies to take the threads all the way to the top. The issue with taking the threads all the way to the top is that you cannot leave these implants equicrestal or supracrestal. All these implants need to be buried subcrestally. And that means if you are going to be planning an implant for a 10 millimeter length, your osteotomy should be 12 millimeters to submerge this subcrestally. So this is not really being discussed in the way we do treatment plans. So when you just look at the design, folks are trying to prepare the osteotomy to 10, and they think the implant will automatically be placed subcrestal. So the osteotomy needs to be longer if you are planning to use some kind of a platform switch. And many of these thread designs, which are being prematurely introduced with the hope that they will prevent bone loss, is now causing an increased rate of failures. So then you have a newer design, as you can see, the polished collar or a machine collar has its benefits. You don't want the threads going all the way to the top because, God forbid, there is crestal bone loss. You are going to set a series of uh, peri-implantitis issues that is going to be very difficult to manage. So I particularly like the design in terms of the way it has been fashioned on the crest. So you can leave this implant equicrestal, slightly supracrestal, or if you want, also a bit subcrestally too. So the issues with having threads to the top, okay, this is what I'm seeing more. When the implant bone level is here and you're starting to see bone loss, now we are going to be seeing a problem in terms of how the crest module is going to resist the forces. So these implants, once upon a time, were kept at the level of bone right here. Now, with the bone loss taking place, it's very difficult to manage any kind of crestal issues that are happening on the surface of the implant. That is related to the macroscopic design feature. But what about an internal connection, which is losing bone at this level, and the walls are going to be that thin? And now, on top of this, you're going to have a single implant that is going to be supported by these implants that are very, very thin at the crest. So this is an example of a case that I had to deal with. It looks like it's a perfectly designed platform switch. You don't see an issue at this point. This is 1 year post-op. And as you're starting to see some kind of crestal remodeling, there is no more bone supporting the crest. So the hoop stresses within this design here is trying to expand. And if this implant is not able to resist the lateral loads, you're going to end up with fractures. Just in the last 2 weeks, I had to refine out almost 6 implants of these designs to be able to get the patient back into function. The patient is upset. I thought these implants were going to be lasting a long time. So many of these referrals I'm getting today are all dealing with implant fractures, fractures happening less than 5 years. So hoop stress are the main reason why we are seeing the fractures. The second problem, these implants are grade 4 titanium. So if it's grade 4 titanium, it's still soft. A grade 4 titanium, the wall should be at least a meter thick. If you have the wall less than a millimeter, the chance of fracture is quite high. And we're seeing this more and more. And this is a collection just from last week. Patient walks in with these multiple implants. You can see the diameter in this case is very, very thin, the wall thickness, and you can see a fracture here. Almost every screw has fractured. So that's because the intimacy of fit is compromised. And then you also have a problem in terms of the stability. The conical connections, if it is not intimately fitting the surface of the implant, you can have misfits that could cause a concentration of the hoop stress, which could in turn fracture these implants. All right. So what are the advantages of the machine collars that we saw in the previous design? These are cases that are over 20 years old. All right, you do not see any evidence of peri-implantitis because the marginal machine surface of the implant is designed in such a way that it's resistant to peri-implantitis. So there is merit to having some of the machine collars. Many of the current practitioners are jumping into the bandwagon saying that I'm going to show you that there is no bone loss with our implants. Our implants, if it's placed subcrestally, you're going to maintain the bone. Take that with a grain of salt. These concepts have been proven and tried in the past 30 years. Just because it's old doesn't mean it's old fashioned and doesn't work. Okay, so sometimes I still stick to traditional concepts. I don't jump into innovations if it's not proven and tried. And these are simple designs which have been showing tremendous peri-implant health. The next biomechanical concept would be about single versus splinted. You have some companies that will tell you that they don't recommend splinted implants or the prosthesis to be splinted. On the other hand, the biomechanical concepts of mesh always tells us, well, you should splint for better stability and rigidity. So who is correct? Who should we believe? If you don't splint it, then you are forced to use one implant per tooth. If you're using fewer implants, you can't leave them freestanding. You are forced to splint it. So which concept should we go by? This is Mesh's quote from his book, where it says there's a lot of benefits to splinting because splinting will decrease the load. It will also distribute the load. And there are a few articles that have pointed towards the support of splinting. And this three-dimensional finite element studies supports the hypothesis that splinting reduces damage evolution. If that is true, then if I'm placing a single tooth implant, I'm not going to be splinting this, will I? I will leave this implant freestanding. So tomorrow, if I have another implant to be placed adjacent to it, I'm not going to tell the patient, you need to redo the prosthesis because splinting is better. Emotionally, we feel that a splinting system is going to be beneficial, right? Because it gives us the feel good factor. Meanwhile, when we are looking at series of implants being replaced, we don't mind having the implant placed here and do another single tooth implant without splinting. So what are the factors that we should consider today to leave it freestanding or splinting? The factors are, number one is the material. Am I going to use a CP titanium or is it a titanium alloy? Number two, what is the shape and size of the tooth that we are restoring? Am I going to have any cantilevers? Are there any cantilevers to my prosthesis? So if I have a tooth that is here, let's say I have an implant here and an implant here, and I don't want to have my crown go out like this and then have another crown like this, not splinted, because this is now going to have a cantilever forces. So it behooves us to splint this kind of a system as opposed to having a restoration where it is side by side, and then you can now tell the patient, I can do it freestanding, and it's okay to have two separate crowns. But then if this implant is not made out of titanium alloy, then it would probably result in some kind of a biomechanical compromise 5 to 10 years down the road. Every implant is going to be successful for the first year, for the second year, for the third year. Show me a case of these designs lasting for about 20 years. That is a true mark of success and survival. If the implant companies are changing their design year after year, it only tells me one thing, that they're having trouble. So a system that's been consistently performing with limited changes in the design is what I would tend to gravitate to in choosing an implant system. So when we look at the indications for splinting, this is a a small example of how splinting can, in fact, create compounding effect on a failure. So this is a picket fence in the Hampton Beach. When a hurricane comes by, it starts to push this fence out. And now the weight of the fence here is going to be transmitted here, and the weight of this is going to be transmitted. So eventually this entire system will fail if it is all splinted. However, this is sand. You can leave a picket fence freestanding. You need to splint it if the foundation is weak. When you have a strong foundation, like a concrete foundation, even if I split this right here, it is not going to affect the integrity of these individual freestanding foundations. So that is how I would be factoring many of my treatment plans. So if it is made out of commercially pure titanium and I want to leave it freestanding, I would be thinking twice. Even when you splint it and you have a cantilever that could compound the forces and you can have fractures side by side. So splinting of two implants does not seem to offer additional value, provided they follow the norms of biomechanics. In this biomechanical model, another article by Joseph Nissan, it says splinting does not prevent prosthetic failure when the crown height space is 15 millimeters or greater. Vertical bone augmentation is recommended. Basically, they're saying do not have a vertical cantilever and a horizontal cantilever. So this is the only study that has shown whether you splint or don't splint, your bone levels don't change. This is a split mouth design by Paula Vigaro. He actually presented at our annual conference, and you can see that the marginal bone levels did not get affected. And of course, you have to really know which implant system was used, what kind of material was used, what kind of prosthetic designs were used. So all of those go into the computation of how the system should be biomechanically built when you're considering splinting versus freestanding. It is also true that when you splint, you're going to lose the connection. So be ready to deal with that complication too. So when you're splinting, are you splinting with a cementable prosthesis or a screw retained prosthesis? The advantages of leaving it freestanding is that the connection are all engaging. These connections are all engaging. These connections could be engaging if they are cementable. If it is screw retained, then the connections cannot be utilized at all. So when you design the restoration, when you want to give the right kind of prescription to the laboratory, understand your biomechanics. Most of the labs, and I'm sure Dr. Park would have seen all the scripts that come to Glidewell, they're usually one-liner. You have to be very specific. This is a prescription that is going to reflect your work. The prescription should be half a page, giving all the specifics to the laboratory. The laboratory is not a magic factory where they're going to give you outstanding restorations just by one impression. Be specific about the anatomy. Be specific about the ridge labs. The more information we provide to the laboratories, the better outcome you're going to get, the better long-standing biomechanical concepts you'll be able to apply to our patients, and you'll minimize the complications in prosthetics. So again, crestal bone loss not affected. Guidelines for splinting generally means when you have a cantilever, you would want to splint. When you're looking at an overdenture that's bar retained, you probably will have to splint. If you're doing an immediate load, you will probably have to splint. And once the bone is healed, you could kind of leave them freestanding. So this is an example of why a splinting could have probably saved this case. Patient comes in, two crowns unsplinted. The patient came with the crowns in the hand, and when I looked at it closely, one of the connections actually came off the implant. So basically, that connection fractured off or sheared off from the abutment. I was looking for the second one, I couldn't find. So I was placing the scanned body, and here you can see that this is completely hollow. And here, if you look at it very closely, there's a thin shim of metal still stuck. And that is why the body did not fit. So one of the complications of these designs is that the conical connection, if it's going to be very thin, it can shear off. So I had to fish that connection out of the implant to be able to take a new impression. So in these cases, implant design, the prosthetic design, the connection, and the kind of occlusion would be paramount. With that said, I would like to conclude this short presentation. I want to thank Dr. Park and his entire team for giving me this opportunity and inviting me again to present to this esteemed audience. I hope I've done justice to the topic.
Fantastic lecture, Shankar. Thank you so much. As always, it was well organized and well documented, as all of your presentations always are. But we've got some great questions. We have a very sophisticated audience, and they've got some good questions. And if you got a few minutes to hang around, let's go through them.
Absolutely, sure.
Okay, so you talked a little bit about the material that the implant is fabricated from, and talked about commercially pure titanium versus the grade 4 alloy that is most commonly used. Is there any benefit to using the commercially pure titanium versus the significantly stronger alloy?
Great question. So the reason why the companies are sticking on to grade 4 is that you can acid etch it. Many of the surface features that are possible with SLA can only be done with commercially pure titanium. So once you get to the alloy, the surface features need to be blasted, and that is giving the surface more surface area. So you can really have a dual edge surface on the alloy.
Gotcha.
So that is why some companies still prefer that, because they are stuck to the acid etching.
You know, it's so interesting, Shankar. You and I have been in this game for a long time, and we know that there used to be tremendous controversies. You know, like what the threading should be like, or should it be an internal connection and an external connection? Should it be a straight implant or a tapered implant? And it's so interesting to me that these designs have just converged, and that everybody's got a tapered implant now. Everybody's got an internal connection. Almost everybody is using a moderately rough surface. Yeah, so it's just funny, you know, whatever the science is, the marketplace has made its decision, and
I
that's
completely agree with you, and that's why fundamental concepts will never change. Every practitioner should know the basics and not just jump into corporate lure. And I really, admire Glidewell for putting this unbiased platform for practitioners like me to be able to share all of this information to your.
Well, you're that very rare, unbiased practitioner that you don't come in from a commercial direction. You come in trying to find out what's the best way to do things. So we appreciate
the
that.
patient should not be hurt. I mean, that's important.
That's right. That's right. Okay, some questions about implant length. You had some very interesting comments about implant length. So one of our attendees says that, is it true that beyond 11 millimeters of length, there is no advantage in length and diameter is more important? And you gave your lawyerly answer that it depends, right? And one of the things it depends on is the bone type. Is that right?
That's correct. So if you can't engage any kind of dense bone to get primary fixation, length becomes a factor. And that's why the chase towards bicortical stabilization became a fad. People started to penetrate the floor of the nose, started to penetrate the floor of the sinus. Now they're going to pterygoids. They're going to anatomical areas that shouldn't be really explored. You can't do that in the posterior mandible. So if you cannot use a length beyond 10, put it to sleep. Let it heal. It is going to integrate. There is no rush. So I would say, yes, it is true that beyond 10, the biomechanical forces don't get transferred. And if it's only a matter of loading, then length would matter.
Very good. Very good. You gave a very nice discussion of splinting versus freestanding implants. And I know that we can both find studies that say you must splint, and then we can find studies that say that there is no advantage to splinting. So on a scientific level, the jury is out. And I really do appreciate the recommendations that you made. But does splinting in itself create biomechanical issues? As far as, like you mentioned, if you have multiple engaging implants, well, then, suddenly that becomes a nightmare to try to get things to fit.
Right. So passivity is the biggest problem. When you try to splint, you need to be really precise. So people don't really follow the one screw test. The shield test is still the gold standard. So if you do a splinting kind of situation where you have multiple implants, put that one prosthetic screw, take a radiograph, make sure it's passively seated. And if it's not, then we probably have to start from scratch.
Right, right. But
Components, big
you're
deal.
not recommending that we try to engage multiple implants, right? Engage the hex, the anti-rotation.
Yeah, so the anti-rotation it's impossible to engage it in a
Good.
fixture
That's why I'm
level.
glad.
It's impossible. So even if these companies are trying to come up with cones, those cones are useless. You need to cut off. You better off with a saucer than having a cone.
Right.
So
I'm so
many
glad you recommend against doing impossible things, because that really that really does make the day much longer. Okay. Um, so a question about occlusal schemes, right? Uh, and obviously that's a very important part of biomechanics. Do you have any rules of thumb that you recommend for occlusal schemes?
Sure. If they have access to JOI, the lead article, I've co-authored it with Dr. James Rakowski. So I've given some guidelines for a full scheme from single tooth all the way to overdentures. So if this group would like to receive that, I can send the editorial as a PDF to Nicole, and they can make it available to the participants. It's a whole slew of cookbook formula
Oh, that
as
would
to
be
how
great.
you do for launch.
Excellent, excellent. Thank you. Yeah,
That
if
would
you
be
send that to
great.
Nicole,
Thank you.
she'll distribute that. And now here's an interesting one from Dr. Courtney. He says that for those of us that only restore implants, not placing the implants, how can we know the bone quality and the implant material? That's a discussion that he could have with his surgeon, right?
So the surgeon should give a surgical report of the how much of newtons of torque was applied to during insertion of the implant, and what is the ISQ level before at the time of placement and at stage 2. So these three values would be paramount. So if they can get some idea, because every surgeon knows what is the torque level they use to place the implant. So the surgical notes should reflect this implant went at 40 newtons of torque. So that'll also give us some guidelines as the stability of the implant, what was the pre-existing levels of stability and so on. So when they go to torque, they would know that it had a minimum of 40, so you can talk to about 30, the prosthetics.
Very good.
So I
Very
would
good.
recommend reverse torque test. That's an old concept. I don't think
that's long gone. That's dead and buried. In fact, only old guys like you and I remember that, right? Yeah, so some questions here about plaque accumulation and whether plaque accumulation can influence the biomechanical failures. So another way of saying that is, what's a greater cause of periimplantitis or implant or implant failure? Is it oral hygiene or is it biomechanics, and how do they work together?
So yeah, it's a difficult question to answer because you can argue both ways. You had the Lindy and Dennis Tarnock camp that strongly believe in the biologic width. And then you also have, Carl Misch and Martha Vidas, who are the proponents of biomechanics, along with Brunsky. So when you look at the periimplantitis, uh, most of the surfaces that are roughened seem to have a propensity for promoting progressive bone loss as a result of plaque. We also know that patients who don't have good oral hygiene may not evidence a lot of bone loss. Now, you're pounding up chunks of calculus from these hybrids, and there's absolutely no bone loss. And patients who keep coming to you every 3 months religiously seem to have continuous bone loss. So, it's very difficult to pinpoint it's plaque or whether it's biomechanics. I would say it's a combination of both. It's very hard to separate biomechanics from biologics.
I agree. That's certainly what I've noticed over the years. We talked about surfaces and how everyone has converged on the fact that a moderately rough surface is probably the best surface for long-term osseointegration. But what about the collar of the implant? There was a fashion a while ago to take that moderately surface up to the very top of the implant, and now, like with the Han implant, we have the machine collar. We don't take the roughened surface all the way to the top.
Yeah, sure. Another reason why they went rough all the way to the top is they were trying to bury these implants. I'm still a fan of the machine collar. That's the kindest to the soft tissue. God forbid there's bone loss, you could still have some amount of peri-implant health. If I had more time, I could show you a lot of my machine collars, long-term survival with high aesthetics. So it's not true that the machine collar will have a lower level of aesthetics. It's the way you treat the implant, the way you place the implant in bone. So I'm a big fan of a machine collar.
Very good. Very good. Dr. Shankar Iyer, it's always a pleasure and an honor to have you on this webinar. You
Thank
share
you
such
so
great
much.
information. Your students in the Maxi courses, your students in the lectures all around the world, they always benefit from your knowledge and experience. And thank you for sharing that with us today. And thanks to our panel, and thanks for all of you for joining us today. Now, we're going to be gone for the next 2 weeks because we've got a couple of Glidewell symposia coming up. But be sure to join us on August 11th, and then we're going to have Dr. Stephen Gold, and he's going to be talking about conservative tooth preparation. And I love his title. It's called Preventing Enamel Cruelty. So thanks to the panel. Thanks to Benco for their sponsorship, and thanks to all of you. And let's meet back here August 11th. We'll see you then. Take care and have a good couple of weeks. Bye-bye.